So, I'm speaking today with Don Berwick, President Emeritus at the Institute for Healthcare Improvement. Don, thank you for taking the time to speak to the Emergency Care Improvement Support Team.
It's my pleasure.
Thank you. As a leading authority on healthcare quality and improvement, we're really looking forward to hearing your views today.
Well, it's a pleasure to join you, and thanks. I look forward to the interview.
Thank you. So, as a paediatrician, what has working with children taught you about improvement?
Well, it's a wonderful metaphor. I mean, children are improvement machines. A healthy child is learning and growing and developing every day, and in some basic way, the ways that children grow and develop are very strong analogs to the kind of activities and attitudes and approaches that we would like to nurture in the improvement of healthcare as a system. It's all about learning. Improvement, learning, change, they're almost synonymous in the world of improvement and also in the life of a healthy child.
How can more clinicians be encouraged to take on leadership roles? And why do you think it's important that they do so?
The second part of your question first. It's very unlikely that healthcare can improve fundamentally in the experience of patients, in the approach to improving health in communities, and even in reducing unnecessary costs without the full engagement of clinicians, doctors, nurses, pharmacists, therapists, as well as managers in healthcare, which the clinicians are just too central to the decisions that are made about the use of resources, about the patterns of care. How they can be helpful is a little more subtle. In a way, they have to both give up some old habits and beliefs and adopt some new ones. That's the only way they can be effective. The old habits and beliefs that don't work center on a kind of heroic or soloist view of excellence in professionalism. I mean, I was trained as a doctor, and I was often told, it's my patient, my duty, my responsibility. It was all about me and me bearing the burden. And we don't want to give that up entirely. The sense of responsibility is really important, but it's a kind of misunderstanding. What makes a patient today safe or allows someone with a complex illness to be dealt with well isn't soloists. It isn't heroes. It's teamwork, interdependency, and also it's the construction of systems, of patterns of care and work that are continually improved and that provide a kind of substrate for the work of people. And those patterns of care, those habits, scheduling systems, the flow in the workforce, the use of information, now the use of artificial intelligence and computer science in healthcare. These are systems, and they have to change, and they can't change against the will or opposition of physicians and nurses and other clinicians. We need to become helpful to the changes, and that involves levels of awareness of systems and teamwork and interaction that we are generally trained for. So I guess those ideas of being a good citizen in a system of care and substituting a kind of sense of cooperation for a sense of heroism would be two examples of cultural change that are very important for clinicians to be able to be helpful with improvement.
And we know that there's lots of great practice out there. How do you think that we can take the good practice that happens in healthcare and deliver it at scale?
Well, we there could mean many different actors. Everyone has a role in that. I think the common feature would be, I'd call curiosity or maybe humility. It's having a bias toward the question, who else is doing this? Who else might know more than me? Where might I find a better example? It's the opposite of what we in the United States call the not invented here syndrome, which makes us say, well, we're different and nothing, we have to invent our own ways. Yeah, of course, every organization, every individual has to find their own pattern of operation at the detailed level, but curiosity matters a ton here. So I'd say, adopt an attitude of inquiry about who else I might learn from. And by the way, who else I might teach, because we have a saying in the Institute for Healthcare Improvement, all teach, all learn. You know, I have something to give, and I also have something to get from other people. That takes, by the way, not just attitude, it takes time and energy. You can't search for great stuff if you don't put some time into the search. On the other side of the coin, say for governments or organizational leaders, the notion is to arrange for people to be able to know about good stuff that's happening. And that's not just printing a glossy brochure. It's actually supporting sociologic interactions that let people have the time and energy to find each other and trusting them. Command and control mechanisms will never achieve spread at scale, or almost never. And there's a sort of trust here that the workforce really wants to learn, and that as a leader, your job is to make it possible for them to learn. That's an attitude shift sometimes at the senior level. There's also a final point about a modicum of energy invested in pure invention. Take, for example, the digital world of healthcare today. It's breaking entirely new ground, very different ways to think about the use of knowledge and communication and alternatives to encounters. And that same attitude of inquiry needs to apply to innovations like that, open-mindedness, prudence, but open-mindedness, so that we're willing to consider entirely new ways of doing old work.
And do you think that there's something people find especially challenging about the science of improvement?
It varies with the person. I mean, it is first all about change. So if for any reason a person is allergic to change or fearful of change in work processes, let's say, or in relationships, they're going to have a hard time with improvement. Just as a fearful child is unlikely to learn. So there's something about accepting change and maybe even, or especially, having fun with it. Improvement can really be fun because you're discovering things all the time. There are also economic issues here, because improvement is about changing systems and processes, and the legacy systems and processes we have, well, those represent job descriptions and workflows and money flows, and so not infrequently, when there's a new way to do something, somebody's business model is going to be disrupted, and we have to make it not crazy to adopt the new approach. So we have to buffer against that, but also people need to realize that change means that old assumptions about the flows of resources may have to change.
You've said, and I think this was in an interview that you did with Simon Stevens, that the proper place for a person is to be at home. Now, this is a concept that we within the Emergency Care Improvement Support Team strongly advocate. And we refer to this as having a home-first mindset. What do you think needs to happen to encourage hospitals to adopt this principle?
First, I thoroughly endorse the principle as you quoted me. Right, at least in the United States, the hospitals have tended to become the center of the healthcare system, when actually they should be nothing but a kind of supplier of last resort, I guess is the way I think about it. People want to be home. They're safer at home. Costs are lower at home, and much that can be done for them could be done at home or in their communities. The Kaiser Permanente has the wonderful phrase, home as the hub, not hospital as the hub. For hospitals, it's partly financial, because if hospitals in your country or mine are paid to be active, to keep the machines on and keep the beds full, if they're kind of a volume-oriented approach to revenue and survival, well, then they would be illogical to try to empty their beds. So I think we can encourage hospitals to think differently by changing the systems of payment and support to make it interesting, I guess financially interesting, for people to be at home. What excites me most of all right now about the scene in the British National Health Service, the English National Health Service, and in the long-term plan that Simon Stevens put out in January, is the concept of beginning to center your system around integrated health systems, integrated health care, and global budgets, control totals at the level of communities or populations served. And once we get out of that mentality of keeping the revenue of the hospital up and understand there's a limited pot of resources to devote to the community, excuse me, and we can use those resources wherever we wish, then we can start to keep people at home, and it's logical to do that. It becomes in everyone's interest to do it. There is some training and development edges to this, although we can say the words integrated care, or community-based care, or place-based care. Those are relatively novel ideas compared to the legacy healthcare systems, and so investments by the National Health Service, for example, in innovations to keep people at home are crucial. And we saw the beginning of that in the era when the National Health Service had the so-called new care models, or Vanguard trust. There were 50 of them, and they broke new ground. And now, I think with the developing of integrated healthcare systems in NHS England, we may see a whole new opportunity for investment in innovations to keep people at home. I must say, you've got a track record here. Hospital at home, some of the wonderful work I've seen on habilitation, the work in the new care models program between nursing homes and ambulance services. Some really innovative stuff with ambulance services and emergency care. For example, I saw a tremendous model in the Isle of Wight where almost everything you could wish about trying innovations that would keep the emergency system oriented toward finding resources other than the hospital and keeping people at home was really thriving. So you've got some great models right there in England.
Moving on from that, and you've touched on this already, what current innovations in healthcare really excite you, and where do you see the innovation occurring in the future?
Oh, the list is long. I already mentioned that digital health, I think, holds great promise. I don't want to fall victim to hype or to over-expectation, but I really am seeing some remarkable innovations in the world of digital care. This includes non-visit care, home care, through the web and the internet, where the visit becomes a sort of dinosaur. And for example, teledermatology now I think is an amazing area. I've seen it thrive at Kaiser Permanente here in the United States. I believe more than 50% of the dermatologic visits right now are no one moves. It's just a matter of someone taking out a camera, photographing a lesion, and sending it to an on-call teledermatologist. I've seen telestroke care thrive. In fact, you've got that going on in some places in England right now. I think that artificial intelligence and machine learning hold great promise. There are threats, but there's also promise if we can find the way to use modern artificial intelligence and machine learning to help really exceed the performance of individual physicians and then support those physicians to make better decisions. And that's underway. There's some great work going on in that in England at Royal Free Hospital, for example, which is working on artificial intelligence in the early detection of acute kidney injury. I think in the world of cooperative care or team-based care, as I say, we saw some great innovations in the Vanguard program, the New Care Models program. I often mention the work of, say, Dr. Duncan Gooch in Derbyshire at Arawash. He and his colleagues developed a system of flow into primary care that made maximal use of non-physician primary care clinicians with great results for patients. Another area is empowerment of patients. Patients and families can take on an awful lot of their own care, and they want to do that with proper support. And again, I see innovations in England around empowering patients and families to do things for themselves. So those are just a few. I'd say once you get curious, once you say where are the innovations that will keep people at home, that will allow what we call the triple aim, better care for individuals, better health for populations, and lower cost, that will allow the triple aim to thrive, you're going to find plenty of them around the British Isles.
And you have been in this unique position where you've gained an insight into both the US and the UK healthcare systems. What do you think that each system can learn from the other?
Well, first, I am deeply indebted to Simon Stevens and to the King's Fund, which have made it possible for me to visit the English NHS repeatedly through year on year, 2 or 3 times a year for quite a while, for the past 5 years. So, and my job when I go there is to travel around the country, see innovations in practice, learn from them, and bring the news that I can gather back to NHS England and NHS Improvement. So that's been a real privilege. You know, in my country, the United States, our healthcare system is not performing very well. We have pretty good high-tech care for people that have very complex needs, as you do. And we need to keep benchmarking each other around what we're doing with cancer care and complex surgery, and you know, the high technology does matter. The United States also has, you know, a strong suit in technical innovation, and that's something that you need to keep your eye on. Overall, however, I think perhaps the United States may have a bit more to learn from the UK than the vice versa about the construction of healthcare systems. Our system is more fragmented than yours, and we have not yet made the commitment that you've made to universal health care, the basic principles of the National Health Service, which is everyone's included, it's free at the point of service, and it's tax supported. These are principles that have made a big difference to you, and we can learn a lot from that. We are innovating in the United States on payment mechanisms, trying to wean ourselves from fee-for-service care. And although you have, in fact, more chance for that faster than we do, given the structure of the NHS, you can watch and learn from those models of health payment innovation that are underway in the U.S. So yeah, we need to exchange lessons across the Atlantic, but you've got a lot to work with in the NHS, and I hope and I know you will maximize that. I must say, by the way, that the long-term plan, which appeared in January this year, is a very, very compelling plan to me. It outlines some extraordinarily important major changes in the way you think about the service and about resource allocation and about the use of digital health and about the location of care and about the value of integration. All of those are important. And one final word is that the long-term plan also has a pretty remarkable commitment to what we would call joy in work, to really understanding you could never, ever get excellent care from a demoralized workforce. And so in that plan, there's at least a promise of recommitment to the conditions of work and the supports, psychological and training supports for the workforce of the NHS that I think is essential. And again, both of our countries can learn from that.
And finally, the Emergency Care Improvement Support Team are currently supporting the delivery of an IHI Breakthrough Series collaborative. What advice would you give to participants of the collaborative in terms of getting the most out of the collaborative process?
Well, the Breakthrough Series collaborative format was developed at IHI in the mid-1990s, and it's thrived ever since then. The basic idea is, as I said earlier, all teach, all learn. Everybody, people that are trying to solve common problems that they share, can do so faster and better together than separately. I'll try one thing, you'll try another, and then we'll talk about it. Or I'll try something and we'll fail, and I can tell you that, and maybe you'll help me figure out why it didn't work. It's just creating a learning community, a learning world, actually, that matters. So for participants in a collaborative, you know, the advice I have is enjoy that, thrive in that, welcome it. So that means be transparent, share everything. We say steal shamelessly, meaning ask your friends in the collaborative what they're doing and find out what they're doing and see how it would work where you are. The concept of learning and sharing from each other. That's the heart of the collaborative. The other thing that's really important in any improvement, certainly in the collaborative mode, is to test soon and frequently. What I mean by that is, in a collaborative environment, a participant, organization, or individual will hear an idea, many ideas that others will bring to the table, sometimes experts, sometimes peers. And the pace of improvement is set not by the number of ideas you're hearing, but by the number of the ideas you're testing. So we always ask in a collaborative, what's the largest informative test of change that you could run next Tuesday? You can change the change, you can change the scale, but you can't change Tuesday. You have to get about work. So if someone asks me in a collaborative to predict which teams are going to be, or which organizations or teams are going to be most successful, I will say the ones that are testing the most changes the quickest will make the most progress. So that's a piece of advice as well.
Don Berwick, thank you very much.
My pleasure. Thank you for having me.